Chronic post-surgical pain is significantly a problem because first, decreased activities of daily living occur. Secondly, quality of life goes down. Thirdly, a lot of overutilization of medication and medical benefits is taken. So it's a very costly problem. And more appropriately, there are ways of dealing with it. The main problem that causes chronic pain for these patients post-surgically is you have peripheral stimulation because, of course, once a surgeon breaks the skin, he's cutting sensory nerves. And so this goes internally. You have the neuron developing in many cases, a neuroma, which has ectopic or spontaneous conduction. You have then dorsal root ganglia changes. You have dorsal horn of the spinal cord changes, which, because of constant peripheral input, if it's unchecked, can induce central sensitization. You then have the pain go all the way up through the brainstem into the limbic system, and then including the hypothalamus, and then past that to the cortex, and then it goes back down, and it's shaded by the limbic system, which tells the patient not just that I hurt, but what the hurt feels like, what you expect it to feel like, how you expect it to feel, and how long you expect it to keep you under, unable to work, unable to function, and so on. So this is all neurologically based, but it's also significantly psychologically based.
Certainly, in any setting, one creates a treatment plan that is personalized. So it's patient-specific, patient-centered, patient-focused, personalized care plan. We have a world of generic drugs. We have no generic patients. Each patient is assessed and reassessed on a personal, individualized level. We have no one-size-pantyhose-fits-all drug combo for everybody. You personalize it for that patient. Their fears or anxieties, the length of surgery, how many surgeries they've gone through, their past experience, their social history, psychiatric history, past medical history, their comorbidities, their renal function, the outcomes of the surgery. So we say to the patient that during surgery you had anesthesia, which was no pain. This is postoperative. We're not in anesthesia. You will experience pain, but our goal is to decrease that on two fronts. How much and how often? So that's the most important issues. So, and then you only promise what you can keep. So we like to take expectations and lower them to where we can be judged, but satisfactorily addressing the patients and their family and personal needs.
Preemptive analgesia is being thought about and has been for decades. In the last 15, 20 years, most preemptive analgesia studies take a anti-hyperalgesic drug like gabapentin, okay, which is used in patients between 1, 2, or 3 hours of surgery. So what I presented was the results of a study I did 20 years ago, where I gave patients a combination of 3 weeks of gabapentin pre-op, 2 weeks of Celebrex with the gabapentin pre-op, and then a month post-op. And over 62% of the patients did not develop chronic post-surgical pain. Whereas today, there are no patients that are getting anything like a week, never mind a day, of analgesia or hyperalgesic, anti-hyperalgesic medication. They're getting an hour, 2 or 3 hours, anywhere between 150 milligrams of gabapentin, if that's what they're using, up to, in one study or 2 studies, 1,200 milligrams, but again, within hours of the surgery. And in my opinion, it's too short a period of time to develop the preemptive type of situation. What you want to do, I believe, is use it for 2 to 3 weeks, so that you develop a new homeostasis, so that the anti-hyperalgesic drugs, in this case combination of gabapentin as well as Celebrex or celecoxib, basically develops a new homeostasis. So the patient goes into surgery with significant changes in how the synapses work and how certain drugs are functioning, rather than taking a drug a couple, 3 hours before surgery, whereas there's not much time to do anything.
Well, first of all, taking into account a period of time where they are face-to-face with the patient and all concerned others in one visit. So they all can be heard at one time and all speak and have all their voices heard. A waste of time is talking to patients. We don't talk to them, we talk with them. We don't hear them, we listen to them. And the patients appreciate that. So sitting at a little medical record form and smiling and looking at them like this really is, to most patients, that's, if I can use the word, aberrant, if anything else. So patient and family needs. What are their expectations? What other pain states do they have concurrently with the surgical pain state that is going to be engaged? Will the patient amalgamate them? That's an important issue. So if they have another pain state and you ask them what their pain is, they may describe the other pain state. You have to isolate it to the surgical pain so that they understand that, why they're there in the hospital, what we've done, and address the surgical pain as opposed to their other pain states, which may be acute on chronic, or because that's what chronic pain is when by the time you see them, acute pain on top of chronic pain. We gave them surgical pain on top of their chronic pain. So listening to them, not hearing them, and addressing their needs, and then follow up with those patients face-to-face to see how they're doing. Never promise what you can't deliver. You're only judged on outcome. And that's an important issue. And remind the patients, if you can, with open dialogue on the outcome that you're trying to achieve to satisfy the family needs and the patient's needs.
If I may add something to what Dr. Barkin was saying, particularly if they have chronic pain from prior to the surgery. They may be on opioids. And being on pre-op opioids is a whole kettle of fish that needs to be dealt with, and that's the sort of thing that Bob, as a just superb PharmD who sees patients and works with patients all the time, deals with. But that's something that must be taken into consideration. And importantly,